Welcome to our Grand Round series. Our Greenberg bladder cancer team are grateful you're here. Of course, seeing you in person would be our preference. However, these virtual platforms have proven efficient for sharing information, education, and most importantly, discussion. First, a couple of updates. This is the first session of the spring semester. We've updated our calendars and are proud to bring you an incredible portfolio of courses over the next couple of months. If you are new, please find our archive program of sessions from over the last several years. Over 20 sessions are available to view. For updated information about the Institute, be sure to simply Google Greenberg Bladder Cancer Institute. Further, I wanted to once again draw your attention to our evolving group of programs specifically tailored around the experiences of women with bladder cancer, developed and led by Drs. Armin Smith and Jeannie Hoffman-Sensis, with the program team of Pamela Getz, Samantha Rockler, and Stephanie Cooper-Greenberg. Their programming details are available on our website, and of course, please never hesitate to reach out. We will send you the details directly. Again, all of this information and more is up on our site. And if we can help you directly, we are only an email away at bladdercancer@jhmi.edu. I'm incredibly grateful to all of you for joining us today for our session. Is it okay to get a second opinion and change my bladder cancer team? Grateful to Dr. Nirmish Singla and our GBCI nurse navigator, Kristen Tyree, for hosting. Dr. Singla is an associate professor of urology and oncology in the Brady Urological Institute at Johns Hopkins University. He serves as the director of translational research in genitourinary oncology and leads the multidisciplinary kidney cancer program at Johns Hopkins. As a urologic oncologist, Dr. Singla is a close collaborator with our Greenberg team, where he works alongside Dr. Hoffman-Sensis in our upper tract urothelial cancers program as co-director. Dr. Singla attended the University of Michigan Medical School. He completed his residency training in urologic surgery at the University of Texas Southwestern Medical Center in Dallas, before pursuing a Society of Urologic Oncology clinical fellowship in urologic oncology at Memorial Sloan Kettering Cancer Center in New York. More than his incredible portfolio of discovery, Nirmish represents the very best of our Institute's focus and commitment to patients and families. I'm grateful to his service to our patients, families, and the larger community. Kristen Tyree is the newest member of the GBCI. She is our upper tract urothelial cancer, or UTUC, multidisciplinary clinic coordinator. She helps our upper tract patients navigate the Johns Hopkins hospital system to see our providers. She does this by collecting outside records, pathology, and imaging results, and helping to alleviate our patients' stress during an already difficult time. An oncology nurse by trade with a master's degree in nursing education, Kristen is a patient advocate through and through, routinely calling herself the patient's teammate, and being a constant and reassuring presence for all new and returning patients at the Kimmel Cancer Center. We are thrilled to have them join us today. Nirmish and Kristen have agreed to speak for about 30 minutes, and then we will jump to a larger group discussion. I would ask you to please submit your questions via the chat feature, and after their conversation, we'll have ample time for group discussion.
All right, thank you so much, David, and thank you, Nirmish, for talking with me, Wasim and Talon for hosting as well, and everyone for attending. I hope everyone's having a wonderful day. We appreciate you taking your time with us today. Dr. Singla, do you have anything you want to say before I start kind of talking about what entails a second opinion?
Yeah, no, Dr. McConkey, thanks also for the very kind introduction, and very excited to kick off the spring series of the GBCI Grand Rounds. It's been an absolute pleasure working with Kristen for our upper tract urothelial cancer multidisciplinary clinic. And, I think this is a great opportunity to highlight many of the questions that we tend to get, and also perhaps highlight the rationale behind the clinic. I think that'll become evident throughout our conversation today. There isn't going to be necessarily a formal agenda in the way of, for example, a formal presentation. I think the main intent today is to allow for more of a conversation we'll start more conversationally between Kristen and myself and try to highlight the salient points that are often brought up related to this diagnosis and related to the clinic itself and the functioning and workflow of our clinic. But then certainly, we do want to make this very patient-centric and allow for ample opportunity for the attendees on the call, and we very much appreciate you being here today with us to ask questions and really make sure that we can help address your needs and also improve our own clinic workflows, as we're always looking for ways to improve.
Absolutely. And like David said, just write any questions you have in the chat, and then here in about 30-ish minutes, we'll kind of go over that to round everything out. I think the most important thing to start off with is, Dr. Singla, is it okay to get a second opinion with us?
Yeah, it's a good question and a very common one that we get. I'll just maybe start by giving a little bit of background regarding the clinic itself. Why did we form this clinic in the first place, and how it may relate to that question of whether it's okay to get a second opinion. Upper tract urothelial cancer is a very niche space. It's not considered one of the most common forms of cancer by any means. In fact, it's actually relatively uncommon and represents only about maybe 5 to 10% of all urothelial cancers, the majority of which would fall into the flavor of bladder cancer or lower urinary tract cancers. The issue as a result of that is that we, unfortunately, it makes it very challenging to study, UTUC for short. And as a result, we also then have to rely on centers where there are higher volumes of this disease space, where there is also the infrastructure and the academic interest to invest in the disease space to make sure that we're providing good quality care that's not just restricted to extrapolation of data from the bladder cancer group, just because there is a very unique considerations that do go into the management for UTUC. Getting to the question of the second opinion, we formed the clinic using that rationale. Dr. Hoffman Sensitz and myself recognized this as an area both of interest for ourselves, but also a growing need throughout the urologic community to better understand this space and be able to offer the latest data and evidence when counseling patients in terms of treatment options and what have you. And so we've formed the clinic initially in June of 2021. So we're about 1.5 years or so into having this clinic available to us. And what we have found is that indeed, I think when patients present to us with the interest of having a second opinion, we have more or less been able to come up with an algorithm that really helps us counsel patients on their options based on the specific scenario on an individualized basis. The concept of getting another opinion can vary because on the one hand, we get patients who come either from an initial referral without a diagnosis. Maybe there is something that's seen on imaging, or maybe a primary care provider detected something related to symptoms that may pertain to UTUC. But then on the other end of the spectrum, we also have patients who have a known diagnosis and perhaps has already had some initial consultation with other providers and are seeking to learn more about what UTUC is and what goes into some of the nuances related to the care. And so from my perspective, I think there's nothing wrong with gathering more information and learning about different approaches to treatment, but also understanding the evidence behind the decisions that we make and offer to patients. And that's where I see the big value for second opinions to be for UTUC.
Absolutely. I know that I joined the team in July, and since I've joined, I would say we've seen like about 24 patients just UTUC specialty wise. And I would say about half of them were actually second opinions. And it's actually extremely common. And one of the things I always worry about is similar to like you said, where it's very scary having a more rare cancer and then finding a team that specializes in it. And then I know that it's kind of difficult for them too, because getting a second opinion can kind of feel like betraying like the person who diagnosed you. So I think hearing it from like a provider, like you said, it's okay to collect as much data about your health as you need. Especially because, you know, it is so rare. I think it also kind of leads into like what happens at a second opinion visit. So we do these like at our MDCs on Thursdays. Can you kind of walk me through like from you and Jeannie's perspective, and I'll talk about mine afterwards?
Yeah, absolutely, Kristen. And I think that certainly having you join as a navigator about 6 months ago has been an absolute boon to our workflow, and has really enhanced the information gathering that goes on upfront, even prior to meeting the patient at the get-go. And so I think that that actually is probably the first step of a second opinion visit, is data acquisition. And you can talk perhaps a little bit more about how that looks from your perspective, but getting information like any medical records, history, any relevant imaging that has been performed for us to visibly look at, and have our radiologist perhaps also render a second opinion on. And then any pathology slides that have been acquired through biopsies or other means would be important also for us to review ahead of time, and perhaps have our pathologists take a look at it here as well. Those are also the pathologists and radiologists are critical members of this team as well. And the reason for that is because sometimes there can be discrepancies between the interpretation that we may render on, say, a biopsy report versus what may have been interpreted elsewhere. And I think that these are sometimes important things to note. And I think across the board, we're looking at sometimes as high as about a 15 or even 20% rate of histological or discordance in the interpretation that we have. And so that's step number one, just so that we can sort of figure out where we stand today, and what is the ask, or what is the role that both myself and Dr. Hoffman-Sensitz can play in terms of the counseling process, and what options we have available, and also whether or not we need to actually get more information in order to help counsel patients on the next steps. Once we have that information, Kristen, again, will very much be helpful in terms of facilitating the process and getting patients into the clinic. Both with myself and Dr. Hoffman-Sensitz, we have a dedicated block of time, typically every other Thursday morning, where we would then have the opportunity, patients would then have the opportunity to meet with essentially both of us. And in some cases, patients may have more of a need to meet with a urologist. So the need is more on the surgical end of the spectrum. And in some instances, the need perhaps may be more towards Dr. Hoffman-Sensitz's end of the spectrum on the oncology side. And in some cases, it's very much a combined approach that would best benefit a particular patient. And so we often will have already had the chance to discuss the case well ahead of time, so we would know before going in, whose side of the conversation I think would be most beneficial. And oftentimes we tend to take a sequential approach in terms of one of us going in first, followed by the other, and they would be able to have an unbiased sort of discussion with each clinician, one after the other, so that it's not that you're seeing one person and then waiting for a referral, for example, to see Dr. Hoffman-Sensitz, a week or two later, but rather getting all the information at once. And once you've had a chance to visit with both of us, then we would be able to present to you our proposed plan, and any other relevant information. And again, Kristen is great about sort of quarterbacking this information and trying to really help patients navigate the next steps, and understanding the diagnosis at large, as well as the treatment options that may pertain to a particular case. Kristen, maybe do you want to chat about your experience so far in the clinic? Because again, I think you do a lot of behind the scenes work, and even on the day of clinic, that sometimes neither Dr. Hoffman-Sensitz nor myself always get to see.
Of course. So I would like you talking about you and Jeannie's perspective, because on my end, a lot of times they like to know what you both do. So being able to kind of encapsulate it like you did is part of what I start off with. So during a second opinion visit, what will happen is there's a lot of pre-work that goes into it, like you said. We usually see people once they've had a biopsy. Ideally, we like to have the biopsy, the pathology, any imaging, any outside records, and recent notes from your urologist. If you're seeing another medical oncologist, from them as well. I collect all of that. I make sure we have your chart made. We kind of proceed, and this is something I get asked quite often, so I like to make a point of it. We proceed like with your care as if you were going to continue with us. So just because you're getting a second opinion, it doesn't affect the level of care you get, the level of effort put into your chart, getting records. We proceed as if you were going to continue with us. And then if you choose to see someone else, that's fine as well. I think the flow of it is like Nirmish said. So a lot of times the first person you'll meet is me while the doctors kind of discuss what the plan is. They've already discussed ahead of time what kind of is going on, and then just meeting with me. I'll give you a folder that kind of talks about the education, what to look for. And this is a folder I give to everyone. And it's so even if you don't decide to pursue care with us, you still have resources that you can use regardless. Visiting with the providers is what Nirmish said. It's visiting with one and then the other to remove bias. And then they kind of come together to talk about the plan. When they're done, I type it up into something called an after visit summary. So everything we talk about, you'll be able to find on your chart. And then after that, it kind of becomes if you decide to pursue care with us, if not. So sometimes people come to the second opinion just to see if what their other provider said is valid. That's totally fine. And then sometimes they come with the intention of switching care. And that's actually going to kind of lead us to our next question, Nirmish. And so if people decide to pursue care, what kind of happens next? And I'll kind of talk about like what I see and then talk about for you and Jeannie. So usually after a second opinion, we do our visits on Thursdays, like Nirmish said. I do a follow-up call on Monday, regardless of if you're going to pursue care somewhere else or with us, to kind of see how you're feeling. Do you have any questions? Kind of let you have the weekend to digest everything we talked about. And then on Monday, I'll call, and that's when people will say, thank you for your time, but I'm pursuing care with someone more close, or they'll say, I would like to switch care to you. In which case, I let the providers know, and then they kind of will, based on what they talked about in their visit, move forward in whatever way is appropriate. I'll have Nirmish kind of talk about his side of it too, if you decide to pursue care with us from a urology surgery standpoint.
Yeah, certainly. I think, first and foremost, when patients come in, I think dissemination of information is what I sort of perceive as at least the first priority. Without any sort of bias as to whether or not, or without even necessarily worrying about whether a patient is going to continue at Johns Hopkins, or whether the patient is simply seeking information to get a better handle on what it is that's going on with UTUC. I approach every patient the same way in terms of presenting the information that we know, the evidence, presenting the standard of care guidelines. There are sometimes trial opportunities for given scenarios that are also worth offering as sort of a unique thing that we sometimes have available at Johns Hopkins. And so to be able to provide these opportunities, I think, and allow for patients to have their questions answered, that's kind of what I see as the first priority. In terms of the subsequent steps, if the decision is made to follow up at Johns Hopkins or to follow up elsewhere, it isn't anything that we take any sort of, there's no sort of personal worry, I guess, from the standpoint of us as clinicians as to, trying to, keep you within our practice. For example, I think, we just want to make sure that we're setting you up for success with your treatment plan, wherever it may be. if it is, a case where you are interested in formally transitioning care to Johns Hopkins and moving forward with us as your primary providers, we want to make sure we have the playing field even with all the information we need. So, for example, there are cases where we may have something equivocal or maybe insufficient information, let's say, from a prior biopsy, and sometimes what on the urology side, what I may need to do is, even though you may have already had a ureteroscopy done by another provider recently, I may elect to sort of remap your urinary tract and take a look again and see, okay, what is truly the extent of tumor or tumors that you have? Where are they located? And then if we can get sufficient additional tissue as a confirmatory means for biopsy and maybe even a urinary cytology for an additional microscopic assessment. This type of information is important to me as a surgeon because that may influence the type of surgical treatment that may be offered down the road or in the setting of, for example, low-grade disease, understanding whether or not a radical surgery is even indicated. And so that is sometimes the necessity to see it with my own eyes is there in order to actually help offer you the full cadre of options that may be available, rather than, for example, using information that is hard to necessarily take from an external source and then come up with a treatment plan. So that is something that is in some cases necessary. Otherwise, if it's a scenario where we have a very clear idea of what the next steps ought to be, it's very much tailored to the individual. So in some cases, it may require treatment with Dr. Hoffman Sensits with chemotherapy or another systemic therapy, followed by surgery. Or in some cases, it may be the need for just strictly therapy alone without surgery as sort of an initial consideration. And so we would then try to make the logistical arrangements on our end to move forward with the treatment plan that we would outline.
Absolutely agree. And thank you for walking through that. I know a lot of questions that come in about second opinions have to do with, will I need surgery? Will I need treatment? Will I need both? So talking more to that, I know really probably addressed a lot of questions. And I think that it's important to know, like, I really like how you pointed out that regardless of where you decide to get care, we're here to give you the information. I think it kind of touches base on one of the other topics I hear a lot whenever I'm kind of talking with patients the first time that they're wanting to come to us. And there's a bit of guilt or fear with switching providers. There's the fear that they won't get the same level of care, or with scheduling, there is a big worry that they may miss an opportunity. So I think hearing from you definitely that we are here to give information and to work with you based on what you need is probably really reassuring for them. I think one of the last few things to talk about before we kind of open it up to questions is kind of, I know the answer, but just for the patient recollection, how long does a second opinion visit kind of take? And like, what is like your main goal going into it?
Absolutely. We want to make sure, we try not to put a time limit to these visits in the sense that, we know it's a complex diagnosis, and patients may come in with varying degrees of information at baseline that maybe for example, the provider may have already provided to them ahead of time. Some may have very little insight into what is the diagnosis and what are the options. It definitely varies on a per patient basis. And again, in some cases, it may be that the conversation is entirely tailored towards systemic therapy options, and the bulk of the discussion may be more so with Dr. Hoffman Sensits, whereas my involvement personally may be a lot less. Or it may be vice versa, where the discussion is entirely surgical in nature, or discussion about low-grade disease, which would be entirely managed on the urology side, with maybe less input from Dr. Hoffman Sensits. And so we try to take a tailored approach that really allows for a sufficient opportunity to discuss your questions thoroughly with the appropriate provider between the two of us. And in some cases, it may be a visit that could be accommodated within even a half hour or less, between the two of us. Or in some cases, it may require a discussion that could last as long as even an hour, between the two of us. Again, we just want to make sure the intent of the clinic is that you can have an opportunity to meet the entire team. So you'll be able to meet certainly all three of us and perhaps other ancillary staff that are part of the team at large. That would be your care team, at Johns Hopkins that specialize in UTUC, but then also make sure that we're having sufficient time tailored for the primary person that would be taking on the next steps in your care. And so again, it can be pretty variable, but we try to carve out the time and allow for sufficient opportunity for these discussions to be had.
Absolutely. I think too, something I like to tell the patients and the people listening is that something so amazing about the MDC setting that we do is that it does allow you and Dr. Hoffman, since it's that time with patients, it's very quality time. It's very centered on them. It's never a rush. It's kind of getting the answers they need and feeling like they're getting the support they need as well, which is so interesting in the MDC setting because you are bringing together these providers, and then pathology's helping review things, and radiology's looking at the second opinions. I think that is so useful, and like it really makes patients feel valued. Like from what I've heard and what I've seen, patients really love this setting. So both of you taking time, and me too, but both of you taking time to do this is so wonderful. I think that just one last thing, and David and Talon and them may have been going to say it, but if you want more information on the Upper Tract program, we have a whole webpage under the Greenberg Bladder Cancer Institute. So you can find my contact information there. If you are interested, if you know anyone going through this, if you have questions, please don't hesitate to reach out to me. We're here to help. I'll help however I can. And I mean, I'm a little biased, but I think we're amazing. So I think with that, if we want to open it up to David or questions or anything else, I think this would be a good time.
Hi, everyone. It was a great discussion. So one other thing I'd just like to emphasize before we turn to the questions is that Kristen and Nirmish and Jeannie are closely collaborating with other academic centers that have special expertise on upper tract cancers. So it's not really, an us versus them situation. It's about trying to figure out what the best approach is for the particular patient standing in front of them. It's really not personal. I can imagine how it might feel that way if you're going in and asking for a second opinion. It's almost like you're doubting your doctor. But I think if you listen to everyone, you'll hear a strong consensus around the idea that you really need to work carefully and thoughtfully on your clinical plan together with as many different experts as you can. So Katie Hahn has our first question. Is atypical urine cytology different from suspicious, and how? And then I'll get to the other part of her question once you answer that.
Sure. So the spectrum of cytology, I'll sort of back up. When it comes to urinary cytology, it's in and of itself, it's not the most sensitive test for diagnosis, and it's important to remember that. And there's a spectrum of results that one can see when it comes to cytology. This can range anywhere from being quote unquote negative for high-grade urothelial carcinoma, or essentially benign. It could be in this sort of this non-specific atypia or atypical cytology, which realistically a number of factors that are benign could also contribute to, and I wouldn't necessarily say that is as informative when we see that type of a result. to more of the suspicious end of the spectrum, which, in and of itself suggests that there is a morphology within the cells in the urine that maybe have an appearance that make you a little bit more suspicious that there could be something there, but is not, a home run for a diagnosis. And then when we see, more definitively high-grade urothelial carcinoma within the cytology, that definitely makes us think of there is some source somewhere in the urinary tract lining that could be anywhere from the kidneys, the lining of the kidneys, all the way down the ureters, to the bladder, to the urethra, even. And we just, when we see that, the intent would be to try and see if we can localize exactly where that source may be. But we don't always tend to find an obvious tumor in these situations. Sometimes there are tumors that are less apparent.
So related to that, Katie asks, what is the percentage of false suspicious cytology?
Yeah, it's a good question, and I do encourage you also. I think Dr. Max Cates, one of my partners, had also actually done a recording specifically on cytology interpretation. I would say that the sensitivity for cytology on the whole is actually very low, especially when it comes to upper tract urothelial cancers. When we see a definitive high-grade urothelial carcinoma, I would say that the specificity is actually usually quite high. In the suspicious category, it's again, it's in the middle ground. It's a little bit more convincing, certainly compared to atypical cells, where again I would say that the predictive value is relatively low, but it's not quite to the same degree as high grade, and we wouldn't really be able to base like a decision for treatment off of that type of finding alone. Simply what it would do to us as a clinician would prompt us to then try and do a more comprehensive endoscopic evaluation to find if there's a definitive source.
So related to that, if CT, urogram, and cystoscopy are clear for 4 years, but cytology is suspicious, how would you follow up with the patient?
It's a great question. So there's a few things that are warranted. So the way that I sort of view the source of cytology is to broadly divide the lower urinary tract from the upper urinary tract. In the lower urinary tract, sometimes if conventional or white light cystoscopy is not enough to definitively visualize either a tumor source or something called carcinoma in situ, then using another type of technology called blue light technology or blue light cystoscopy is a way that can sometimes enhance our detection of tumors that are otherwise not visible through white light. And so that would be a way to enhance the detection within the lower urinary tract. Sometimes employing what are called random bladder biopsies, which would be getting samples from different parts of the bladder, including the prostatic urethra, would be a way to also enhance that. If we're not able to definitively see anything, using that approach, it would allow for another set of eyes under the microscope to take a look. If that remains unrevealing, a more comprehensive way of evaluating the upper urinary tracts would entail a combination of, or some one or the other, doing either selective cytologies. So in other words, getting a sample of urine from each ureter and trying to minimize contamination to optimize the interpretation of results, to see if maybe the cytology could be localizing to the right side versus the left side, and or if it ends up coming to it either in a staged fashion. So let's say you do that and you see that, okay, it looks like maybe it's coming from the right side. Then simply going forward with a ureteroscopy to directly visualize the urinary tract would be the true gold standard to really assess for tumors that may not be picked up even by conventional imaging. If need be, one can try to do that approach on both sides, but just to minimize the risk of cross-contamination, if it is localizing to one side, I often tend more often to prefer trying to get one side assessed at a time. And maybe the use of intraoperative retrograde pyelograms is a way to get more information of the upper urinary tract. But there are more ways to evaluate it, but we would just try to be thoughtful in our approach.
Thanks, Nirmish. So Debbie asks, are clinical trials discussed during the multi-D meeting?
Absolutely, and Kristen has an important role as well in some of these discussions. But there are trials that are open and trials that are also upcoming. And prior to visiting with patients, when Kristen, Dr. Hoffman, Sensitz, and I all discuss individual cases, we also try to think about what options are available from this trial, from the standpoint of clinical trials, and make sure that we can present those options as well to patients. Kristen, maybe you can have maybe you have an additional comment related to that as well.
Absolutely. I agree with everything you said. And I think that the question that's very common with clinical trials is just kind of like who talks about them, what kind of happens with them. And I think that what usually is the protocol with clinical trials is when we're reviewing data before your visit, and then we go in to talk with you, we will also propose what kind of clinical trials you are eligible for if you pursue care with us. So a lot of times people will say they looked on the website and saw all these clinical trials, and then I try to reassure them by saying that the providers definitely discuss this during the visit if you're a candidate. I know Dr. Hoffman, since it's especially, will go into a lot of depth with the oncology ones specifically because the chemotherapy qualifications and everything, and her research team with that is like phenomenal. So I do know that it's discussed pretty regularly beforehand, and then we go in and kind of discuss it with patients.
Thank you. So Karen Godfrey has a question. Can a patient receive care from your center while maintaining local urology practice? Can you collaborate the care needed, especially for those who travel a long distance, for your opinion?
Absolutely. Certainly, I think Dr. Hoffman Sensitz isn't here at the moment, but maybe Kristen can help on kind of discuss things from the oncology side as it pertains to coordinating, for example, systemic therapies with local oncologists where recurrent visits over a short period of time are necessitated for treatment. From the urology side, it depends a little bit, of course, on each individual scenario. But by all means, I usually will maintain a fairly well documented plan and really try to highlight all the points of our discussion within my dictations. And that way, in the event that it's logistically easier for someone to resume care with their local urologist, at least it's fairly well outlined if there are any questions. And of course, we're always accessible to have that discussion. There are, patients, for example, who may elect to have surgery with me, like a radical surgery, and then their subsequent treatment plan, from my perspective, is just routine cystoscopic surveillance of the lower urinary tract at periodic intervals. That's a very common thing that we may have patients who are traveling from afar interested in simply having their routine cystoscopies done locally, and that is very much something that we'd be happy to facilitate in any way.
Absolutely. Speaking from the medical oncology side of things, I think it is very, very possible to keep your local urologist and to pursue systemic medical oncology care with us. I think that if it's in relation to long distance, we do that quite a bit, actually. It's just a matter of whenever you're going to pursue care, if you do live a long distance, what we always like to remind people is that sometimes systemic therapy, chemos, radiation, things like that can be multiple days in a row, or it can be day 1, day 8. So you will be likely in the area more often and having to stay kind of close if you're getting that kind of therapy with us. But maintaining an outside urologist and primary care and all of those things are actually advised. So whenever you're done with like the specialty care here, you can transition closer to home, so you don't have to travel as far. I think it's actually extremely common. I can think of a few people right now that do the same thing. So it's pretty usual. It's not odd. We just have to kind of know who they are and how to get in contact with them.
Thank you, both of you. So an anonymous attendee has written, I had the experience of having a second opinion pathology review significantly disagree with the initial report, and was surprised to learn that this happens so often. It can make a huge difference for the treatment plan. Is this level of disagreement discussed within the field, and are there proposed solutions? Is it just entirely on the patient to make sure that they seek that second opinion?
Yeah, it's that's an insightful question, and it's hard to give you a clear solution to it. We certainly rely on the expertise of our dedicated genitourinary pathologists when it comes to reviewing, for example, biopsies or even cytologies that either we obtain ourselves or that are sometimes obtained elsewhere and referred, sent over to us for review. I think it is something that is alarming to see the rate of discordance, and I think maybe there would be benefit to having a pathologist on the call here today to comment a little bit more, perhaps, on what is actually seen under the microscope and to what degree is there a subjective assessment made. Certainly, I think we maybe it's part of our bias, but I think we do have a lot of fidelity in our and trust in our pathologists, just because we know that being dedicated GU pathologists, and in some cases having a clinical and academic interest that's sometimes very specific even to urothelial cancers, let alone genitourinary pathology, we often find that there may be certain nuances or certain aspects that they pick up on these specimens that perhaps could have been overlooked elsewhere. As a field, I think it's something that is hard to necessarily reconcile just across the board. You may even find that in pathology conferences, there could even still be disagreement on certain levels about, what constitutes a particular grade of a tumor, or what constitutes a certain percentage of a variant histology of a tumor. And I think that these are still evolving concepts, and sometimes the discordance is higher when we're looking at an initial interpretation that was done by a pathologist that has perhaps less experience in this particular field. And that's actually the key reason why we do make such a push to receive those slides, is because we do want to make sure that at least there's either concordance, or at least we have a sense of what our pathologists feel is the true diagnosis, especially if it is something that would impact the approach that we would offer to a patient.
And just to elaborate a little bit on what Nirmish just said, we have something called histologic variance in urothelial cancers, and our pathology community, academic community, spends a lot of time talking about discordant results among pathologists, even experts. So this is a problem that the field recognizes. There are ways we're thinking about trying to democratize things. One way is perhaps by using molecular approaches, sequencing, to visualize things that may not be visible to the eye, but still are clinically significant. The other is, if you attend our meetings these days, you hear a lot about artificial intelligence and machine learning. And another thing that we and others are doing, our collaborators at Weill Cornell and other places, are that we're taking the digital scanned images of your H&E slides and using artificial intelligence to find features in those slides using a computer that then, of course, if made robust, could be used by any center anywhere. In fact, you could even send the digital images to somebody's computer and have the computer spit back a diagnosis. So we do have great pathologists here, and also our colleagues have great pathologists that we talk to a lot. But it's a problem, we recognize it, and we are trying to fix it. So Doug Sharp asks, what are your thoughts about a situation where a patient has two primary urologic cancers, for example, non-muscle invasive bladder cancer and prostate? Would it make sense for the bladder expert at Hopkins to manage the care and the prostate expert to manage the prostate, or have one urologist cover both? That's a Nirmish question.
Yeah, it's also, these are all great questions. I think it depends a little bit on so I think I'll say it, at Hopkins we tend to be very, very super subspecialized, but at the same time being all of our urologic oncology providers are fellowship trained in urologic oncology, so that does sort of span the whole whole spectrum of urologic cancers, prostate cancer actually being probably the most common, just in terms of its incidence and epidemiology. We do have a prostate cancer multidisciplinary clinic as well at Johns Hopkins, and if there is, on an individual case basis, if there is utility in having the prostate cancer aspect discussed in that setting, then it allows for the opportunity to engage with other players that are more prostate centric. But that being said, my practice and some of my colleagues' practices as well, we are often very comfortable with treating both malignancies and coming up with an appropriate plan. Prostate cancer happens to be another hat that I wear in terms of my practice. And so I do primarily manage a lot of prostate cancer patients as well as urothelial cancer patients. And so it really boils down to sort of the comfort level of your provider and whether there may be a utility in involving multiple urologists in your care.
Thank you. And I guess neither one of you mentioned this, but we also have a tumor board every Monday morning where cases of all genitourinary malignancies are presented to a diverse group of individuals for input. So in a case like that, if there were any questions, Nirmish would have prostate experts to bounce his judgment off of. So Brenda Harrington asks, why doesn't GBCI use blue light cystoscopy for routine surveillance? And she means high-grade upper tract urothelial cancer cystoscopy.
So blue light is a technology that is available, there are certain scenarios, in my opinion, where there's benefit. I would say that the majority of scenarios of doing a cystoscopy, if there's enough suspicion, oftentimes you would have the ability to pick up on, say, a tumor, or sometimes there are areas that are questionable that a combination of visual assessment and cytology together can be very beneficial. The blue light cystoscopy, the story behind that was really to help with identifying those carcinoma in situ lesions that may not be as readily visible with the naked eye on white light cystoscopy alone. And fortunately, when it comes to cytology, I know I mentioned that cytology generally has a low sensitivity across the board for urothelial cancer diagnosis and screening. But fortunately, in the setting of CIS, carcinoma in situ, we actually do have a pretty high, and I'm talking, upwards of 90 to 95% or even more sensitivity, since these tend to be the types of tumors that actually do tend to shed cells into the urine more frequently. And so situations where localization within the lower urinary tract is really key, those would be scenarios where I tend to employ blue light cystoscopy in my practice. There are some considerations related to logistics of routinely administering the drug, the ability to get biopsies more so under anesthesia than in the awake setting where most of our flexible cystoscopies are being done, and then a cost-benefit discussion, of which there are also several papers now that have been published looking at this. It is something that we do certainly offer at the GBCI in selected scenarios. But certainly taking a thoughtful approach to each case to see if it's truly something that would be beneficial, and also combining that with an operative setting where you would simultaneously have the ability to get biopsies under anesthesia would be the setting that I would actually find most of the benefit, if we really need a better visual assessment if you can't see something under white light alone.
So Brenda wanted also to emphasize the patient also had bladder cancer in addition to high-grade upper tract. So does that change your response at all?
Well, the blue light technology is only applicable at the moment to lower urinary tract tumors as it is. So it isn't unfortunately yet a technology that we can apply for better visualization in the upper urinary tract. I think honestly, it's a great idea if there is something that we could enhance our visual assessment through ureteroscopy with something similar to blue light or otherwise. I think that would be a huge breakthrough for upper tract urothelial cancers. But really at the moment, we're restricted for blue light applicability to the lower urinary tract, so specifically bladder cancers.
So Katie has a related question. What if you're allergic to blue light? How do you detect CIS? I think you touched on that, but maybe you can go ahead and reemphasize it.
Certainly, yeah. I think there may be a few contraindications to the use of what's called hexaminolevolinic acid, which is the compound that's used for blue light. That's basically instilled in the bladder for some duration of time, usually anywhere from 30 to 60 minutes prior to undergoing the procedure with blue light illumination in the procedural suite. And so, unfortunately, if that isn't an option available, then oftentimes the standard approach would entail a combination of visual assessment with white light. There are also other forms of other filters that have been used in the past to enhance narrowband imaging in particular, that has been used in the past for enhancing the white light visualization. Cystoscopic assessment, cytologic assessment, which would be, of course, microscopic and done under a microscope afterwards, and then some combination of random bladder biopsies for any areas that may be perceived as suspicious or otherwise, to try and take a systematic approach to sampling the bladder and the prostatic urethra. Those would be the other approaches that we would then be able to utilize if blue light weren't available in our arsenal for a particular patient.
I just also wanted to point out that Nirmish is leading an effort within our group to develop liquid biopsies in urine. And so that's possible that a combination of all these different approaches would give us a much more accurate estimation of disease burden and potentially disease aggressiveness in the right course of therapy. So stay tuned on that. Are there resources for patients who come to Baltimore from out of town for care, housing, etc.? Kristen, maybe you can tackle that one.
Absolutely. So, as I mentioned, whenever people come to us, I give them a folder that has a bunch of education in it. It has a bunch of Maryland resources like the Cancer Society, the Hope Lodge, different places that they can stay while they're getting care here. We actually are very fortunate at Johns Hopkins that we have like a partnership with the Cancer Society. And so when anyone comes here and they need a place to stay if they're coming out of town, we can put in like a little like note to the coordinator and she'll easily get people set up there. She's fantastic. So the minimum you have to be here for to be able to do that is 3 days. That's the only thing that kind of puts like a wrench in the plans occasionally. But if that's not plausible, we have other options we can do. But to answer the question, yes, there are a lot of resources and a lot that are very familiar with the Cancer Center.
Thank you, Kristen. So high-grade T1 with CIS covering 25% of the bladder, misdiagnosed for 3 years. After 21 BCGs, now the shortage at his facility, her facility, their facility. What is the best treatment without BCG? Can one continue chemo installations long term? That sounds like a Nirmish question.
We're happy to address that. Again, it's there may be some nuances that pertain to each individual case. From the sound of the question, 21 installations of BCG makes me think that there has been a pretty decent response to the BCG. To be honest, usually our approach would be 6 induction courses of BCG followed by 15 maintenance doses. So if you're already at the kind of the 21 treatment mark, then usually cystoscopic surveillance alone is what would be the next step, since you've already completed both the induction and the maintenance phase of the BCG. However, if there were some concern, for example, with recurrence, it depends a little bit on the nature of the recurrence. So is it high grade, is it low grade, is it superficial, is it more invasive, as well as the time duration that it took from the last BCG dose to the time that recurrence had occurred. So that actually defines, there's kind of a spectrum that has emerged as far as what are the different flavors of BCG failure, if you will, that would sort of determine whether a re-challenge with BCG could be warranted, or what's an emerging strategy here at Johns Hopkins, certainly, and elsewhere, is a doublet combination of 2 therapies, chemotherapies that are instilled into the bladder, gemcitabine and docetaxel. And that is something that we often also use with retrospective evidence that has also seemed to show that it's also an effective salvage strategy for patients who fail BCG. There has also been press about some new agents that have been that gained FDA approval as well. Some of Dr. McConkey's former colleagues have also been involved in the development of that agent, and there are other techniques as well and other trials that are under development or ongoing accrual that may be effective options too. So it is definitely a very academic space for us, but every case is definitely nuanced based on the nature of the treatments that have been received.
And just another FYI, so Max Cates and Noah Hahn are launching a non-muscle invasive bladder cancer MDC, where, again, as you've heard today for upper tract, the intention is to provide a very comprehensive and balanced clinical plan for patients with complicated forms. The space there has gotten very complicated, as Nirmish just said. The good news is that I think that the FDA is looking at results from our SWOG S1602 trial, where another BCG strain was analyzed. Hopefully the results were positive and the FDA will give us another strain. So Debbie, I think this is based on the pathology question that the anonymous attendee asked earlier. How often do you decide to repeat a procedure done outside of Hopkins?
Yeah, it really depends a little bit. If one thing that to me is something that I often will want to pursue a second look for would be patients who have a pathology report that is low grade, and the reason is because what we have found in our own retrospective series and others is that there actually is a reasonably high rate of undergrading if you were to compare patients who had an initial low grade biopsy and then at some point did undergo a radical surgery, sometimes even as high as 50%, depending on the series, may be seen where there's a discordance between low versus high grade. And so really making sure that I feel confident with the sampling that was done for cases like that before subjecting to a patient to maybe a kidney sparing approach, I think is paramount, so that we're not under treating a patient. Cases where there simply isn't pathology, so maybe just a visual assessment, but a biopsy was never obtained from the upper urinary tract, is something that surprisingly we've seen on a few occasions, and something that I think is really important to do. Cases where it may be equivocal about the location of the tumor, are there surgical approaches that we could undertake that may still spare the kidney, but effectively treat high-grade disease? That depends a little bit on how high or low and how many tumors there are within the upper urinary tract. So that's an important aspect that would determine, if there is a need to take another look. Or if the pathology is equivocal and we're not sure, even after our pathologist has interpreted outside biopsies, because these are often very, very small samples that they have to look at. So those are cases as well where maybe a second look would be important. And so we try not to do it on a routine basis because, these are not pleasant procedures by any means to have to subject patients to. But at the same time, if there's a risk of potentially treating the wrong disease state, then doing this extra look sometimes can be really important.
So the anonymous attendee had a comment that he or she sought a second opinion at a leading facility, not Johns Hopkins, and the clinician had not even read the file or viewed the imaging. It's extremely discouraging. I think your program sounds excellent. I just want to thank you for providing all this information. Thank you for saying thank you. Appreciate it. And Brenda also says, thank you, Dr. Singla.
My pleasure.
And Doug Sharp, Hopkins still uses blue light, only uses blue light for rigid cysto or not flexible clinic, correct?
By and large, I would say that the blue lights that are being done have predominantly been within the OR setting. To my knowledge, certainly I haven't used it in the outpatient flexible cystoscopy setting as of yet. I can't speak to what my colleagues have been doing, but I don't believe we quite yet have the infrastructure to do it on a routine basis for our outpatients. There is a potential capability to do so. It would be a matter of coordinating. Most of our cystoscopies are being done at Green Spring Station now since we've transitioned over there. So getting the infrastructure set up, including the logistical aspects of instilling the agent prior to doing the cystoscopy would be paramount in order to get a program like that set up. There are centers that are certainly doing it for the flexible cystos, but again, in my opinion, I think that being a little bit more thoughtful about which patients are receiving the blue light, taking a more selected approach, and also having the ability to get simultaneous biopsies are important because, if you do a blue light cystoscopy in the outpatient setting, maybe you see something, but maybe you don't have the ability to readily biopsy at the time. You may still have to put the patient under anesthesia at a later point in time with blue light technology to relocate the area that may have illuminated. So it sort of defeats the purpose to some degree, where again, in the setting of CIS, oftentimes your cytology does have a pretty high level of sensitivity for those particular scenarios.
Thanks, Nirmish. So Brenda, to answer your question, what about liquid biopsy for bladder cancer surveillance? When will that be part of care? So hopefully soon. So we're working with one company that has a CAP/CLIA approved test that should be available. We just came out of a meeting hosted by the National Cancer Institute, where we convened a bunch of experts to talk about this. And we're at the stage now where we're integrating these measurements into our cooperative group clinical trials. There are several candidate great tests, and we need to have a bit more experience with them before they become part of care. But I'm going to optimistically suggest that work is going on right now, and it will happen very soon. And Katie says, thank you all for an excellent informative presentation. Thanks, Katie. And she also says, an educated patient is an excellent patient. Kristen, what do you think about that?
Well, I think all of our patients are excellent, but I do think that having this education is very anxiety reducing, which is the point of everything we do. We're here to help, and we're here to kind of reaffirm that it's okay to have questions, to seek second opinions, and to inform yourself, because I think at the end of the day, being your own advocate is so important. Like, we're going to advocate for you as much as we can, but you know your body better than we do. So I agree, but I think all of our patients are great. So
thanks, Kristen. And thanks to all of you, and thanks in particular to Nirmish and Kristen for hosting such an engaging session today. I look forward to seeing you all at the next one. Until then, stay safe. COVID isn't gone yet, and be well. We hope to see you soon.
bye, everyone.
Thank you all for coming and for your engagement. It's really been a pleasure.